Okay, good evening, everyone. My name is Janine Walsh. I'm Communications Coordinator for the Franciscan Action Network, and we would like to welcome you this evening to our event, the COVID vaccine, a Franciscan Perspective. As you entered the room this evening, you may have noticed that you are automatically muted. We are expecting a very large crowd tonight, and so we're going to keep everyone on mute to reduce background noise. And we will ask you to enter your questions through our chat function, which is located at the bottom center of your screen. We will be monitoring that throughout the evening and collect and collate similar questions and present those at the end of the panelist discussion. If the chat is distracting to you, you can click it open and it will open to the side window, which is a little bit easier to ignore if you're one of those people that gets distracted by that. We are recording this event this evening for distribution after tonight, and we thank you for being here. And with that, I would like to send it to Stephen, our Executive Director.
Thanks, Janine. As Janine mentioned, I'm the Executive Director of Franciscan Action Network. We are exceptionally gratified to have such an extraordinary panel of discussants this evening to talk about the COVID vaccines and all of the concerns that surround it. So let me just jump right in and begin to introduce the panelists to you this evening. We're exceptionally delighted to have His Eminence Cardinal Sean Patrick O'Malley, OFM Cap. Cardinal O'Malley was professed as a Capuchin Franciscan in 1965 and ordained as a priest in 1970. He earned a PhD in Spanish and Portuguese literature from the Catholic University of America, where he taught from 1969 to 1973. Cardinal O'Malley founded Centro Católico Hispano, Hispanic Catholic Center, an organization that assists immigrants. He was named Bishop of the Diocese of St. Thomas in the Virgin Islands in 1985, of the Diocese of Fall River, Massachusetts in 1992, of Palm Beach, Florida in 2002, and was named Archbishop of Boston in 2003. He was created Cardinal by Pope Benedict XVI in March 2006. Cardinal O'Malley serves on the United States Conference of Catholic Bishops Committee for Pro-Life Activities, the Subcommittee for the Church in Africa, and the Subcommittee for the Church in Latin America. Also, Cardinal O'Malley is a member of the Board of Trustees of the Catholic University of America. And in 2010, Pope Benedict appointed Cardinal O'Malley as Apostolic Visitor for the Archdiocese of Dublin. In 2013, Pope Francis appointed Cardinal O'Malley to the Council of Cardinals, and in 2014 as President of the Pontifical Commission for the Protection of Minors. In 2018, Cardinal O'Malley was elected Chairman of the Papal Foundation. What an honor to have you with us this evening, Your Eminence. Next is Dr. Maurizio Cattaneo, who is the co-founder and CEO of Artemis Biosystems, a company specializing in process intensification for viral vector and vaccine manufacturing. Maurizio is the co-inventor of the patented VHU technology, which enables the rapid manufacturing of the VLP vaccine for COVID-19. The VHU technology was validated through a nimble grant together with Mass Biologics for the cost-effective biomanufacturing of lentiviral vectors. If I stumble over these words, Dr. Cattaneo, forgive me. Maurizio directed and designed a multi-product pilot plant facility for the preclinical and clinical manufacturing of early phase clinical material. He is the founder and CTO of Ivrea Pharmaceuticals, an early stage startup developing a melanoma therapeutic and responsible for CMC to support phase 1 and 2 clinical trials. Maurizio is a certified pharmaceutical industry professional and holds a Bachelor of Applied Science and Engineering from the University of Toronto and a PhD in chemical engineering from McGill University. Welcome, Dr. Cattaneo. Next, we're pleased to welcome Dr. Edward T. Ryan. Edward T. Ryan, MD, is a physician scientist, professor of immunology and infectious diseases at the Harvard T.H. Chan School of Public Health. He is also professor of medicine at Harvard Medical School and director of global infectious diseases at Massachusetts General Hospital in Boston, Massachusetts. Dr. Ryan's work focuses on global infectious diseases, especially those afflicting individuals in resource-poor areas. Dr. Ryan has specific expertise in vaccine-related work, including in resource-limited areas. Dr. Ryan has served on expert and advisory committees and working groups for the World Health Organization, the Institute of Medicine, National Academy of Sciences, U.S. Centers for Disease and Control and Prevention, the U.S. National Institute of Health, and is a previous president of the American Society of Tropical Medicine and Hygiene. Dr. Ryan is a fellow of the American College of Physicians, the Infectious Diseases Society of America, and the American Academy of Microbiology, and has published over 300 peer-reviewed journal articles and book chapters on enteric infections, infectious diseases, vaccines, tropical medicine, and global health. And he adds here in his biography that he is the nephew of the late Sister Kathleen Ryan of the Sisters of St. Paul. Welcome, Dr. Ryan. And we're very lucky to have this evening Colleen M. Walters. Colleen is the Vice President of Mission and Ethics for Baycare Healthcare System, formed in 1997, and this includes the Allegheny Franciscan Sisters Legacy Ministries of St. Anthony's in St. Petersburg and St. Joseph's in Tampa. Colleen Walters joined in 2019 to provide system leadership for mission integration, including faith community nursing. Most recently, her team and the Baycare Faith Community Nurses provided COVID vaccination support in multi-county clinics, I guess across Florida. She has over 40 years of health experience and earned her master's degree in healthcare mission at St. Thomas Aquinas Institute of Theology in St. Louis, Missouri. We are so pleased to have you this evening, Ms. Walters. So with that, we really just an astonishing collection of expertise this evening. With that though, I'd like to ask His Eminence to lead us in prayer to begin this evening's discussion, and then perhaps to offer a few opening remarks. Your Eminence.
Thank you very much, Steve. And now let us begin in the name of the Father, and of the Son, and of the Holy Spirit. O God, Trinity of love, from the profound communion of your divine life, pour out on us the torrent of your love. Grant that the love reflected in the actions of Jesus, in his family of Nazareth, and in the early Christian community, grant that we, his disciples, may live the gospel, discovering Christ in each human being, recognizing him crucified in the sufferings of the abandoned and the forgotten of our world, and of those sick and suffering, and also to recognize the risen Lord in each of our brothers or sisters who makes a new start. Come, Holy Spirit, show us your beauty reflected in all the peoples of the earth, so that we may discover anew that all are important and all are necessary, different faces of the one humanity that God so loves. And this we ask in Jesus' holy name. Amen.
Amen.
Well, first of all, I want to thank Steve Schneck and the organizers of this for bringing us together to talk about the COVID vaccine, a Franciscan perspective. Our Holy Father, in two of what I call his very Franciscan encyclicals, touches on this. In Laudato Si, the Holy Father talks about this world as being our common home. And the pandemic has really helped us to experience just how connected we are in the human family and how we need to take care of one another. In the Holy Father's more recent encyclical, Fratelli Tutti, we're all brothers and sisters. And this reminds us that we are responsible for each other. And the decision to be vaccinated is not just concerning my own well-being, but my responsibility to care for others, to make sure that I am not transferring a deadly disease to another person, and doing all that I can to shut down this virus in our world. When the first vaccines were approved for use in our country, questions were raised about the ethical nature, since in some ways aborted stem cells that had been, tissue cells had been used either in the development or the production. The Holy See was very quick to address these ethical problems and to assure people that it's perfectly licit to make use of these vaccines. And today, where we see how we're in a race against time, as more and more variants are coming about, and we know that the immunity that is offered by having become ill with the virus oneself, or because of the immunity that's given by the vaccines, though that immunity is going to run out at some point. And we really need to shut down the variants before they can develop into an even more dangerous virus that perhaps will be vaccine resistant. And so I know that many people have a great worry about what are the unforeseen effects of this vaccine. But we seem to be very happy with the results that we see in our world and what difference it has made where the vaccine has been available. And so the Holy Father himself was very happy to be able to publicly receive a vaccine, to assure people that this is the ethical thing to do, and it's a way that we can help to protect not only ourselves, but all of those around us. And so I'm here tonight to encourage everyone to, if they have not had the vaccine, to please do so, to be able to help take care of our common home, take care of our human family, and stop the spread of this terrible disease. We see that in India, in the last month or so, over 1,000 doctors have perished taking care of the sick. And we're also very concerned to see that in many of the poor countries of the world, people are still waiting for the vaccine to arrive there. There's a very big social justice issue that the developed nations need to face. There is a social mortgage on all wealth and also on the technology and the science that we enjoy in the first world countries. And we need to work very, very hard to be able to share these resources with the whole world, with the entire human family.
Thank you, Your Eminence. We have a few Spanish speakers in our audience, and I wonder if you might say a few words to them as well.
Desde luego, con mucho gusto, estamos aquí esta noche para hablar de la vacuna contra el coronavirus y la importancia de que todos tenemos la oportunidad de vacunarse, no solo por nuestro bien personal, sino para el bien de la comunidad, para que no vayamos a transmitir la muerte a otras personas porque estamos transmitiendo a ellos este virus tan terrible. La iglesia está empeñada en animar a la gente a recibir la vacuna. Muchas personas estaban preguntando si fue una opción ética, pero el Santo Padre mismo ha recibido la vacuna para darnos un ejemplo y él nos está animando a todos a recibir la vacuna cuanto antes.
Thank you, Your Eminence. With that, let's open the panel to talk about some of the issues related to this. And if perhaps we could begin with you, Dr. Ryan. I wonder, given your background, if you could give us an overview of where we stand with COVID now. I'm down at my beach house in North Carolina, and I mean, from the way people are acting, the attitude here seems to be that the pandemic is over and, you know, we don't have to worry about the things that we worried about over the last year and a half. Is the pandemic over, and should we be worried about COVID still, and how much and why and so forth?
So first of all, I'd like to thank the organizers from the FAN and Dr. Schenk for the opportunity to be with you tonight. And it's wonderful being with such a wonderful panel. So the quick answer is no, the pandemic's not over. We have another 18 to 24 months of this battle. We're in a bit of a reprieve right now in the United States. But in the United States, so I think part of this is that we feel that the numbers are better, and therefore we're out of the woods, and we're not, as alluded to by His Eminence. We're going to get burnt with the Delta variant, and I'll come back to that. But even in this time of relative nicety, we are diagnosing in the United States 10,000 individuals each day, and we are losing on average about 300 people a day from COVID. And that's during a time period where we think it's over. To put that 300 a day into perspective, not all those individual lives, if you add that up, that's 100,000 deaths over the next 12 months. And we would consider that a horrible flu season. And here in the United States, I'll come back to this in a second, here in the United States, we're in a lull, but because the world is not in a lull, the world is on fire still. Right now, the world is diagnosing about 350,000 cases a day. And that's just the tip of the iceberg. Excuse me, that's just the tip of the iceberg, because most of the countries don't have diagnostic capability. The number's probably closer to 1 million to 1.5 million people a day. Reported deaths are 7,000 a day. To put that in perspective, that's 2.5 million people over a year. And the deaths are probably 5 to 10 times higher than that. So right now, global deaths are up to a little over 3 million. The real death toll here is probably 10 to 15 million. So we're already passing World War I total deaths. And when all this is over, we'll be on the level of World War II deaths. This is really a story of two worlds. In North America, we have about 70% of the eligible individuals who have been vaccinated. We still have a lot of room to move there. Overall, it's only about 46% of our population, but if you take North America broadly defined. But in sub-Saharan Africa, only about 3% of the population has been vaccinated. So it's really a tale of multiple worlds here. Now, I'll be an optimist for a second and say that we're only 15 months into a global war. And in that 15 months, not only have we identified the virus, not only have we figured out a lot about it, not only have we improved treatment, but we have actually invented and have deployed now over 15 vaccines globally. We have 7 workhorse vaccines, and we have immunized over 3 billion people on the planet in 15 months. From a vaccine that didn't even exist to immunizing 3 billion people on the planet, we as a species have never turned up the gas like this before. We've never immunized close to this number of people, and we certainly haven't been moving with the safety and alacrity up until now. As His Eminence mentioned, there's really nothing like a pandemic to remind us that we're all one species and that therefore we're all one people. The problem when the world is on fire, even from our little protected bubble in the present, is that the virus is mutating zillions and zillions of particles every single day. And there's going to be a natural selection, and the cream will always rise to the top. The things that spread more quickly and that evade the immune system will rise to the top. And as long as the world is on fire, we're all on fire effectively. Delta is a perfectly fine example of that. The Delta, we will flare again here in the United States. It won't be as high as we saw in this winter, but by July or August, you're going to see Arkansas, Missouri, Mississippi, Alabama, Utah, Arizona go hot. Those are the places in the United States that have relatively proportional low number of people vaccinated. The vaccine works against Delta, but in those populations, only 15 to 30% of the population is vaccinated. And so it's going to fly through those populations, and we're going to flare again. And unfortunately, every death from here on out in the United States is effectively a vaccine preventable illness. And so we're really going to expect 100,000 deaths over the next 12 months for stuff that can be prevented. And then let alone the big battle of how do we get vaccines to the rest of the world and staunch their bleeding as well. And maybe I'll just stop there.
Let me turn to Colleen Walters. Colleen, you've been on the front lines giving these vaccines, it sounds like, or at least in managing those who are giving it. Who's not getting the vaccine here in the United States, and why?
Well, it's interesting. The pandemic has shown us where our health disparities lie, and that's in the poor, the marginalized, African-American communities who don't have a good history of trust with healthcare. And in some of the Latino Hispanic communities as well. And so what we've tried to do is to go into those communities, but you have to have a level of trust. And that's where our faith community nursing has helped us. These are communities that are connected to churches. And so they're already trusted resources. And then they have a lot of misinformation. And so having that relationship and having someone within a wisdom community to be able to connect so that they can trust the vaccine and trust the people giving it to them.
Do you think there's a special onus on Franciscans in this regard? I mean, should Franciscans be doing more?
I don't know that there's an onus, but I definitely think that's part of their DNA. I think it's part of their call. So I was not surprised at all that you weren't looking at doing something like this, even this call. So it's who they are. At least that's my experience of the Franciscans.
Let me turn to Dr. Cattaneo. As a vaccine expert, doctor, can you tell us that the vaccines are really effective? I mean, you've obviously looked at the numbers better than we have. Are they really effective? And I say this because, well, I mean, I think we've all seen stories about members of the New York Yankees getting, COVID even after they've been vaccinated. So, I mean, how effective is it exactly?
So the data right now shows that protection from hospitalization and severe disease is 100%. And in the real world, it's 94%. Now, if you're getting just a first dose, your protection is around 76%. And overall, in the real world, effectiveness is around 80%. The increased efficacy with a longer dosing interval is around 81%. And overall, in the real world is 73%. So these numbers show that, the vaccine is effective. What is really, you can say, novel about this vaccine, first of all, that it was developed in a record time. Vaccine development usually takes about a decade, about 10 years or longer. And these vaccines were developed in about 1 year. If you count the academic research that went into it, then we can extend that to about 3 years or so. Now, this is a record in terms of being able to develop a vaccine. So what is also very important to note is that since it is so much faster to develop a vaccine using, for example, either the mRNA or the viral vector vaccine from AstraZeneca, Johnson & Johnson, or the mRNA from Pfizer and Moderna. what we see is that we can incorporate mutations in the development of, and do it very, very rapidly in the development of new vaccines. And again, going back to what was discussed from a, you know, in terms of like protecting one world, right? So there's a very large collaboration called COVAX. Now, right now, about 142 countries are supplied with vaccine through COVAX. Now, this is an incredible feat from a manufacturing point of view. For example, AstraZeneca partnered with the Serum Institute of India, you know, and they are now the largest initial supplier to COVAX. Now, over 80% of the total allocated doses that are allocated doses that, you know, basically from COVAX, they go towards low and middle income countries. So so the goal there is to target low and middle income countries, especially with vaccines like the AstraZeneca vaccine and Johnson & Johnson vaccine.
Thank you. I've got an odd follow-up, but you know, I have to give it a little bit of air. I think that it's I mean, it's not something that I believe, but it's certainly going around. I have a sister-in-law that believes that there are things in these vaccines that allow governments and other agencies to track them and maybe do other nefarious things. Dr. Catania, is there even the tiniest bit of truth in that?
There is not. So in this case, really, you know, industry and science, the science behind the vaccine, it's really, you know, it's really put forward a you can say, you know, the most ethical way to, you know, to develop and to manufacture these vaccines. And so from the point of view of, you know, of trying to, you know, discredit, you know, there is no evidence out there. There is no evidence.
We've heard that at a lot of our vaccinations clinics, anywhere from the spectrum of they're putting a chip into you to giving you the virus.
Yeah. How do we beat these? I guess these falsehoods. How do we combat that? It certainly seems to be. And like I said, even my sister-in-law seems to be believing it. Do you have any idea, Colleen?
One of the things I think that was somewhat of a missed opportunity for us as a rollout this big is education before the vaccine was actually out. There is a lot of misinformation. You know, we looked at that group of 25-year-olds who aren't getting vaccinated. They're the information generation, and it doesn't help to have a vaccine that you ask, well, how long does it last? We don't know. Well, when do you need a booster? Well, we don't know. What are the side effects? We don't know. And so I think that that's the biggest challenge is as we get it past this emergency authorization use and it gets FDA approval, I'm hopeful that we'll see more people who will take the vaccine once it moves out of that category. I'd be anxious to see if the physicians agree.
In fact, I was just going to turn to Dr. Ryan. And first of all, Dr. Ryan, I wonder, I mean, since you look at the populations, you know, that are getting the vaccine and not getting the vaccine, could you tell us a little bit about that? Who is getting here in the United States? I understand the world situation, but here in the United States, what are the populations that are not or seem to be resistant to getting the vaccine?
Yeah, so I guess a couple of broad strokes, some numbers. So the main purpose of the vaccine is to prevent death and destruction. And so the people who have the highest risk of dying are the older with comorbid conditions. We've done a reasonable, for those greater than 65 years of age in the United States, 78% have now been fully vaccinated. And about 88%, almost 90% of those individuals have received at least one vaccine. And in the next 2 weeks or so, we'll wrap that up. When we get above the age of 18 is when we start to fall off. It really falls off with age. And when we get to over the age of 18, we're looking at about 57% of individuals, which is not bad, have been fully vaccinated. When you look at the 12 to 18, which just came online, that's a population that will probably, I'd be amazed if we get above 40 to 50% in that population.
Wow.
So age is a primary factor, and it's because the risk-benefit calculus that everybody or the parents do weighs what's the likelihood that I'm going to get really ill or die versus an unknown potential problem in the future. And so what you run into is a sin of commission is somehow worse in our brains than a sin of omission. And because of that, people prefer to pass on the decision. So that's age, number one, with the risk-benefit calculus. Then there's race and socioeconomic aspects. Black Americans have a historically lower rate for all health interventions, as alluded to, and that follows with this vaccine. And also individuals of Latin American descent also are less likely to get the vaccine. Now, what's interesting is there's room here for the Franciscans to make some progress. If you look at the Latinos who have not been vaccinated, about a third of them want to get vaccinated, but they view it as that they just, and if you ask them what the problems are, many of the online systems in their states require ID, require a social security number, et cetera, even though legally they shouldn't. Number one. Number two is they don't want to take off a day from work. And number three is even though the vaccine is free, they don't want to pay the out-of-cost expenses. So if there's a way to get to that community, you get a fairer bang for the buck. But I'll be a pessimist here and say almost 70% of all Latinos in the United States who have not yet been vaccinated don't want to get the vaccine right now because of that risk-benefit calculus we were talking about. If you look at whites, about 90% of people who haven't gotten it, who are white, don't want to get it now. So it's not an issue of access or anything, it's that they have just made the decision with the risk-benefit calculus for themselves. And if you look at blacks, it's about 93% who haven't gotten it, don't want to get it right now. So the low-hanging fruit here would be the Latinos, where outreach, et cetera, will actually save thousands of lives over the next 12 months.
That's actually, let's all write that down. I think that's a good target for, for those of us in the Franciscan communities to really go for it. That's very, very helpful.
I would agree with Dr. Ryan. We did that in one of our health clinics that's out, a 20-year established relationship, a partnership with our health system as well as the diocese. And these are farm workers who migrate through the United States. And we had a lot of conversation about trying to get the one shot, which unfortunately wasn't available to us, but was supported by our bishop for that population because we were worried we weren't going to get them to come back. We did use one of the others, and 4 weeks later, we had every one of those patients come back for their second shot. They did want it, but we didn't ask all of the questions about government paperwork or anything like that. And so that was where and we had some that were very, very skittish and very concerned. So having the relationship with them helped, the trust relationship. But you're absolutely right.
Yeah, interesting. One of the things that I've heard from people that I know that are resistant is a concern about the side effects of the vaccine itself. I don't know what it was like when you got your vaccines. I assume we're all vaccinated here, but for me, I had a sore arm for an afternoon, but there are other stories going around, particularly of other kinds of things, everything from, rare heart conditions to, people who are down for 2 or 3 days as a result of the vaccine. Maybe I could ask you first, Dr. Ryan. How should we be afraid of the effects, the side effects of these vaccines?
Well, I guess it comes down to what the verb afraid means. There's always the aspect of an unknown aspect, but I guess a couple of things. Number one, the short answer is no, you should be more afraid of the illness. You should be more afraid of your actions leading to the death of others by transmitting the virus onto others. That's the stuff you should be afraid of. Now, can any doctor tell you that these vaccines are perfectly safe? No. People die drinking glasses of water on a yearly basis because it goes down the wrong pipe. So anything can kill you. Having said that, a couple of broad strokes, these vaccines are very, very safe. Talking about the ones that are in the United States, they've been hundreds of millions of dosages have been administered. The illnesses that are common is a sore arm or some low-level fevers or chill, and that can last for 12 to 18 hours, and some people a little longer. It tends to occur with either of the dosages for the 2-dose ones, and it's more severe than we've seen with other vaccines, but that's probably because it's really revving up the immune system. And so that's really a marker for those of you on the call who've gotten your shingles vaccine. You probably had very similar reactions. And the reason why that vaccine is so much better than the old one is because it revs up the immune system. So that's actually, it's actually a good marker that the vaccines are working well, which is why Dr. Cattaneo can quote 90 to 100% efficacy, because these are really good vaccines, number one. Now, if you talk about the more severe side effects, you'll see that there was the TTS, which is that's the clotting one that came on the radar screen in Europe, et cetera.
Right.
That does appear to be a risk, but I'll give you what that risk is. The risk is 1 in 300,000. And that risk of 1 in 300,000, people don't do well with stats. They can't gradate what a risk is. You say the risk is anything and they think it's going to happen to them. That's how lotteries make their money, by the way. But the 1 in 300,000, to put that into perspective, that's the risk of being struck by lightning over the next 2 years. So if you don't go to bed worried about being struck by lightning, you shouldn't worry about getting the vaccine and having that complication. Now, and that's on the DNA vaccines. On the RNA vaccines, the thing that's risen to the top that you saw with the CDC ACIP analysis last week was some inflammation in the heart that appears to be mostly young men. And so between the age of 18 to 24, for males, our best quote of a risk for that is about 1 in 15,000. So that's much higher than 1 in 300,000. But I'll put that in perspective for you. That's the risk of dying in a car accident over the next 18 months. And so there's going to be 100 Americans who die today of car accidents, but nobody today is going to die from getting the vaccine. So once again, you have to put risk into perspective in order to move forward and not get frozen by anxiety. And so we also have options here. If I had a young man in front of me who says, I don't want to take a 1 in 15,000 risk, I'd say, fine, I'll give you the DNA vaccine, because almost everybody who gets the clotting disorder is a woman, and almost everybody who gets the cardiac disease is a man. We have options. So it can always work with you.
Dr. Cattaneo, since you were involved in testing some of these vaccines, I'm curious if you have other thoughts about the after effects or side effects.
So these vaccines, before they're released, they have to go through really stringent quality specifications, and even in the manufacturing, we're talking about 6 Sigma, meaning even having batches that don't meet the specifications. It's like 1 in a million. So from a quality point of view, there is such an enormous amount of both guidance from the FDA that has to be followed. And we did see an issue when the Johnson & Johnson vaccine was produced in a facility in Maryland, and that had to do with just a mix-up of some of the ingredients. All of that was taken care of. It did slow down the manufacturing. So really, the reason why manufacturing is like the white elephant in the room here is because these vaccines are so new that we had to literally invent a new manufacturing method, making sure that the quality is the quality that is that is demanded by the FDA.
Cardinal O'Malley, you know, if in fact, I mean, Dr. Ryan pointed out that, and Colleen Walters as well pointed out that American Latino populations maybe aren't necessarily resistant, but are not presenting themselves for these vaccines at the levels that we need to see that happening. I wonder if you might just paraphrase some of the remarks about the safety of the vaccines and the you know, the relatively mild side effects and so forth to the Spanish speakers on our call. Could I ask you to say a few words about that to our audience?
Certainly, I would be happy to. And just for your information, I have been involved in 2 of the Zoom seminars for the Hispanic community, both in the United States and in Latin America.
Oh, bravo.
And on one of them, we had over 10,000 participants, and people obviously have a lot of questions and are very worried. But the Hispanic population, particularly in our country, immigrants, are living in very close quarters, using public transportation, working in jobs and nursing homes and grocery stores and in other places where there's a lot of exposure to the virus. And of course, for that reason, have had a very high incidence of the coronavirus in their communities. Me han pedido que dijera algo sobre lo que el doctor acaba de hablar sobre la seguridad de la vacuna, de que mucha gente tiene miedo de vacunarse porque temen los efectos colaterales y las consecuencias negativas que puede haber. Pero como nos ha explicado, esos casos son rarísimos y mucho más peligroso es no vacunarse y correr el riesgo de morir del coronavirus en vez de lanzarse a recibir la vacuna.
Thank you. I wonder if we might turn to some ethical discussion for a moment or two here. Maybe we could begin with you, Ms. Walters. You know, let's say I'm one of these 20 or 20 somethings that feel completely invulnerable. You know, that you know, I'm in great health, and it's true or not, you know, I've heard that people like me, you know, seldom experience the disease of COVID as more than you know, a severe cold or something like that. So you know, I rationalize that it's highly unlikely that I would die or even get a serious disease from COVID. So ethically, why should I feel obliged to get the vaccine? I mean, what does morality tell us here?
What's interesting, I have a 26-year-old, so I had that conversation with her most recently, and she's been vaccinated, and she talked about her friends that have been vaccinated. She works in the service industry, and the one thing that I know about her and the you know, kind of the kids that she hangs around with, you could call them kids at 26, is they are very much community focused. So I think if you could reach out to them on this sense of what's in the greatest good and the common good, in that conversation, I was actually it was very enlightening that, you know, that would be an avenue that this generation, her generation, is more interested in what is in the greater good for the community. And so I think we have an opportunity with that population to have them see something bigger than themselves. You can see that they do get involved in community giving back, and they think about and those kind of things. So I think we have an opportunity with them to help them to look at it that way. I would be interested to see if the data doesn't show us a disparity around education levels in that age range. And it would fall in line with what we saw earlier with some of the challenges with some of the Latino community and the African American community as well.
Cardinal O'Malley, in Catholic social thought, there's this idea of the common good that is in public life, the good by which we're to measure our engagement in public life, in fact. It seems to me isn't this kind of a common good argument that Colleen is trying to make here? Isn't the argument, the disease might not hit me so badly, but but me getting vaccinated allows me to protect so many others, and therefore serves the common good of the whole community, that regardless of my self-interest, my own determination of risks and rewards, what I should be thinking about at least as well, if not more, is what I owe to the rest of the community, and what my vaccination or lack of vaccination could lend to that. Would you agree with that, Your Eminence?
Certainly, and Pope Francis has made that point eloquently on a number of occasions, that some people think that this is a very personal decision, but it has so many social repercussions. And so it's not just a matter of protecting myself, but also protecting the more vulnerable people around me, the elderly, those who have different diseases and conditions that would make them more vulnerable, those who are unable to be vaccinated because of health conditions that they have. All of them could be the recipients of the virus from someone who is young and healthy, and perhaps has even a symptomatic case without any manifestations in their own life, but at the same time could be dealing death to others. So it certainly, there is a very strong social and moral obligation to consider the repercussions of a decision to be vaccinated or not to be vaccinated.
I'm struggling with the right language here. Would it be wrong to say that morality requires us to be vaccinated?
I believe that
Yeah, I didn't mean to put you on the
have
spot.
a very strong reasons not to be vaccinated, and I know a lot of people don't share that opinion, but it certainly is mine, that I don't think people can simply dismiss this as, well, this is my personal choice and I don't want to risk any of the side effects, or I don't know what the future implications are. And of course, that's a lot of speculation, but we know without doubt how lethal this disease can be. And it's not speculation, that is a fact.
Your Eminence, I've quoted Pope Francis, and I hope he said this, because I tell people he said it's an act of charity. So if he didn't say it, I'm sure he was thinking it.
Well, that leads to a question for for Dr. Ryan and Dr. Catania. What level of vaccinations do we really need worldwide? What level of vaccinations do we have to have before we can really say that we're over this disease?
Maurizio, you want to go first?
Actually, no. I'll let you go first.
Perfect. The real answer is we don't know. And the reason why is it depends on the definitions of what do you mean by breaking the back. I'll come back to that. And as the new variants come down, their transmission rates go up. And because of that, the herd immunity that would be required to break the back of the new variants is constantly rising. So I guess I would take an evolutionary view of this. We're never going to get rid of SARS-CoV-2. It's going to become a virus. Now, this has happened. This is the 8th time this has happened to our species. This is the 8th coronavirus that has jumped into humans. People know MERS and SARS-1, but there's many others, HK19, there's many other coronaviruses that account for about 15% of common colds. And so what'll happen to SARS-CoV-2 in 3 to 5 years, most people would predict that it'll become a standard cold virus of kids, and perhaps of more severe disease in immunocompromised older individuals. But for us to get to that level, we have to go through this tunnel where the virus is new to our species and wreaking its havoc. So the answer is we're not going to eradicate this virus from the planet, number one. Our real job is to get the burden of disease low enough that new mutants are not really a major problem, and it becomes a true routine childhood vaccine. Now, to do that, I would imagine we would have to immunize probably about 60 to 70% of the world. And unfortunately, well, not unfortunately, but God's going to immunize most of them, to be honest with you. So, the vast majority of people around the planet are going to get infected before they get vaccinated. And so, yes, the vaccine will kick up their immunity and make it better. But I think we have about another 18 to 24 months before we actually get through this at a species level on the planet.
Yes, I just want to second that. And, there was a study done in Israel, and just recently we heard about the Delta variant resurgence, or, having some impact in Israel. Now Israel had basically, almost the entire population vaccinated, at the order to 80-90% of the population. So the most important thing again is to make sure that the severity is reduced. So as these variants come into play, what's really a key here is to limit the number of hospitalization and deaths. So I think that's really the key. The key is to be able to, so the vaccination is really important, even with, especially with the vaccines that we have right now, so that we can reduce that death rate and severe hospitalization.
So is this then going to be something like my annual flu shot? Every fall I'll need to get another COVID vaccine or a booster, or whatever the right term would be?
I think it's too early to say that. I do think that if Delta flares, which most people are predicting, I suspect that we will recommend individuals at least over the age of 50 or so to get a booster sometime this fall or winter, although the decision has not been made yet. If Delta doesn't flare, you might not see that booster. So I think some of it will be driven by what happens. But I'll go back to something I said: we're never going to eradicate this virus, and it's getting more and more infectious. And so something which should be communicated to individuals who've not yet been vaccinated is they will eventually get this virus. So the only question really should be, do they want to be vaccinated, markedly decreasing the likelihood they're going to die and or spread it to others, or not? They're not going to dodge this bullet. This bullet's coming from them either next week, next month, next year, 5 years from now. So the answer is, do you want to do it on your own, or do you want to have the vaccine in your body before it comes for you?
Wow. Well, let me again thank this extraordinary panel. I want to open we've had so many questions popping up in the chat. I want to open it to that, but let me just say personally how truly grateful I am for all that you are doing against this terrible disease. And it just does something with my Franciscan charism. I just feel that we have a mission here that we can't ignore. Thank you all very much. And I'll turn it over to Janine to field the questions from the audience. Janine.
All right, we've had, yes, quite a bit of discussion and question going on in the chat. Thank you to everyone. One of the first things that we discussed this evening was our ability here in the US to make as many vaccines as we have, and of course, the rest of the world. So I wonder if one or two of the panel could address what happens with the vaccines that the US is making. Are they going to go out to the rest of the world? Are we hoarding them? There's an enormous gap, as we have discussed, between the richest countries and the countries in need. If there's knowledge about that, if we could just address that for a moment.
Maybe I'll take a
Mauricio, yes.
yes, I'll take a stab at this.
Mhm.
So currently, over 60% of countries are receiving the vaccine in low and middle income countries. Now, we have heard the issues, the manufacturing issues coming from the Serum Institute of India. They were slated to manufacture about 1 billion doses, but they only delivered about 100 million doses. So, there are still big issues with the manufacturing and the delivery of the vaccine. Depending upon the vaccine, there are vaccines that are quite stable, and you can use, they call it the supply chain or the cold chain, just like any other vaccine. And those are, for example, the viral vector vaccines, the Johnson & Johnson and the AstraZeneca. So those vaccines are more stable in warmer countries, and you can follow their standard procedure. So it's easier to deliver those compared to the Moderna and the Pfizer vaccines. On the other hand, the manufacturing is somewhat more complex with the viral vector vaccine. So I guess it's a bit of a balance that you have to. But in terms of trying to meet the targets, manufacturing organizations or contract manufacturing organizations they're all coming up to meet the task at hand. So to the detriment of other things, for example, gene therapy and other areas, these organizations have now focused strictly on manufacturing vaccines. So they've taken people away from other areas and then focused them on the manufacturing of the vaccine.
Very good. Thank you. Thank you. We also had some discussion about concerns that people have heard from various people in their community. Several questions came through about, does the vaccine change the DNA? Does it affect pregnant women? Does it prevent embryos from being implanted? Sterilization? Maybe Dr. Ryan, could you speak to the answers to those?
Sure. There are currently 2 types of vaccines approved, authorized in the United States, and there'll probably be in the next 3 months or so another version, which will be a protein version. I'll get started with the RNA vaccines, which are the primary one that has been used most commonly in the United States. For those who don't remember their high school biology too well, the way we're made is each of our cells has DNA, which is the best way to think about that is the library, and then that makes a Xerox copy that's an RNA. And then the Xerox copy actually goes out and makes the protein or the book that it makes up our cells. So the vaccines, actually, some of them are DNA vaccines, some are RNA vaccines, and the ones that'll get approved in the next 3 to 6 months are protein vaccines. The RNA vaccines, RNA is very, very unstable. That's why it has to be frozen at such temperatures, et cetera. And because of that, it does not stick around in your body. That's why you need 2 dosages. That's why it needs to be frozen, et cetera. The RNA and it's non-replicative. This is not a living thing in any way, shape, or form. It's a Xerox copy of the gene that the protein of the virus makes. Now, and if you want to say, oh, I don't want to get RNA into my body, well, I'm going to tell you something. This is an RNA virus, right? So your choice is, do you want a doctor or nurse to inject a little amount of RNA that's going to protect you? Or do you want to wait till you get the whole virus into your body, replicating, taking over your cells, and making a lot more RNA? So on a theoretical level, you should choose that type of vaccine. It's a perfectly fine, safe vaccine. I'll come back to pregnancy in a second. The DNA vaccines account for a smaller percentage in the United States. That's the Janssen or Johnson & Johnson, although that's a workhorse around the world right now with the AstraZeneca vaccine, the Oxford AstraZeneca vaccine. That one is a piece of DNA, but it is non-replicative. So it cannot reproduce itself. So it doesn't intercalate into your DNA. It doesn't change your DNA. It doesn't change who you are in any way, shape, or form. And if you're afraid of having DNA in your body, well, I'm going to tell you that about 9 out of 10 cells that as you are sitting there, 9 out of 10 cells in your body are actually bacteria that have their own DNA. And you are a minority of the number of cells that comprise you as a human entity. And so you're already dealing with DNA from other organisms anyway, and this one's non-replicated. The last one is the protein one, and it hasn't come down the pipe yet, but it will. And most of us are used to protein vaccines. That's the tetanus vaccine we all had as kids, the pertussis vaccines. Those are proteins. And for those who are at some level can't deal with the RNA or DNA aspect, they can just wait for the protein vaccines technically to come down the pipe, and they could get that one. With regard to pregnancy, yes, we have no biological reason to think that this affects pregnancy, fetus formation, childbirth, or anything like that. There was a lead New England Journal of Medicine article about 2 weeks ago. Now, we can't randomize people, right, because of the ethical issues. So we can't take 5,000 pregnant women and give them the vaccine and 5,000 to go out and die of COVID. But what they did is they took thousands of women who were pregnant who received the vaccines, and they looked at their outcomes. And since they couldn't randomize them, they had to look at outcomes in comparison to historical. Well, how many people usually miscarriage? How many people usually have, malformation or something? And those numbers were no different than historical controls. Okay. And we also know, I've cared for many pregnant women at Mass General who we almost would lose the mom and the baby because of COVID. This is a big stress on the body. And so it's a very clear decision from a clinician standpoint of pregnant women should easily get this vaccine. And if it was my wife or my body, I'd be more worried about the virus than I would be about the vaccine.
Okay, great. Thank you very much, Dr. Ryan. Appreciate those remarks. The next few questions I'm going to direct actually to Cardinal O'Malley. We have had several people in the chat discuss going back to Mass. Is it too soon? There are mixed messages coming from clergy. There are questions about, they're looking for tips about how to worship in the new era of trying to open back up. What would you say to those?
Well, it depends on the local bishop to lift the dispensation and invite people back to embrace the Sunday obligation again. And we've done that here in the province of Boston. However, we have told people that if they still feel as though they are at risk, or if they have not been vaccinated, or if there's some other reason that they should consider themselves still dispensed from the obligation. Mm-hmm. At the same time, I've asked the pastors in the various parishes to maintain a section of the church that would be available for people who want to wear a mask and have the social distancing. And I think that has given comfort to people that don't feel as though they're ready to rush back into a situation where they'll be surrounded by people without masks and with the social distancing. And so far, that's worked out pretty well.
Very good. Thank you very much. Colleen, I wonder if you might be able to field this one. We've got a couple of conversations going on. The difficulty with and frustration with trying to advocate for the vaccine. It's still a free country. Teachers being forbidden to give any kind of opinion on the safety or efficacy of vaccines. People with vows of obedience. How exactly would you guide them as far as speaking out in favor?
The wonderful thing that I've been able to have access to is a lot of support both within the church community. The USCCB has a wonderful document that talks about the vaccinations and encouragement of people to be vaccinated. Pope Francis has also been very eloquent about the vaccinations. From my perspective also, especially in those areas where there is more challenge to getting the vaccine, I really think reaching out to clergy and those within those communities where people are connected would help, because they have a trust relationship. And so, really trying to focus on those communities, and then your own personal, testament to having the vaccine. Yes, I've been vaccinated. Yes, I had a sore arm, but for the common good of the community and trying to get past this pandemic, I agree with Dr. Ryan. I think we're always going to be dealing with COVID. And I think if for those that aren't vaccinated, I do have that same concern that as this vaccine, or as the COVID virus continues to mutate, that we are going to see a resurgence in this country. My personal belief is I think the people in this country are just over the pandemic, and I think I'm a little bit worried that that's a little too soon and too quick.
Yeah. Great. Thank you very much. Dr. Ryan, or maybe Mauricio, I had a question come through about regarding, are there studies regarding those who have had COVID? How long does that natural antibody last? And in that situation, where is the moral obligation to be vaccinated if you've had COVID?
Yeah, maybe I'll let Dr. Ryan answer this one.
Sure. So if you've had COVID, you sort of come in three flavors. You have the asymptomatics, you have the mild or moderate disease, and you have the severe disease. And the reason I break that out is because multiple studies have shown that the milder your disease is, the less antibody response you had. So many individuals who had asymptomatic or mild disease, they actually really have no meaningful protection. And we've seen people get COVID now more than once. And sometimes it's a much more severe disease the second time. And so, but the quick answer is, even if you have high level disease with high level immunity, it seems to wane over 3 to 6 months. And what's interesting is that for most people who had wild type COVID, naturally acquired COVID, their immune systems, their immune response is lower than what we see for a comparable population who have been vaccinated. And so you want to, if you have the illness, I strongly recommend to my patients that they should still be vaccinated. I tell them to wait 90 days from their onset of symptoms, but then they should get vaccinated at this point. When you see Delta and when you see Epsilon's the new variant that you're going to see in the news over the next 2 to 3 weeks that's coming out of Peru and Chile right now. That's why Latin America is on fire again. And so when Epsilon comes to you and Delta comes to you, you want to go against it with as high an antibody level as possible. And so even if you've had it, you want to boost it higher with the vaccine. The answer is three months to get it.
Gotcha. Thank you, Dr. Ryan. With the mention of Latin America, I think I'll turn back to you, Cardinal. The question is coming in from our Latin American, our Spanish-speaking community. Mixed messages from the Catholic clergy are some outright discouraging the vaccination, while also appealing to the religious and pro-life sensibilities of the Latino community. Also, they have distrust in federal, state, and local programs that collect the personal information for vaccinations and how it may or may not impact immigration status. Could you maybe speak, and feel free to answer in Spanish if that would help?
Well, you're talking about Hispanics living in the United States, I presume.
Presumably, yes.
Well, in New York City, a group called Somos has been very, very successful in vaccinating millions of residents of the city, and many of the best vaccination sites have been in churches and places where people feel safe. There are many undocumented people out there who are afraid to go to a government setting, as it were, to receive any kind of vaccine that would perhaps put them at risk of being deported. And so certainly the church stands ready to do whatever we can. I'm distressed to hear that some priests might be discouraging people from getting a vaccine, particularly since we see how devastating the virus has been in the Hispanic community.
Eminence, would you mind, we have, as I indicated, some Spanish-speaking audience.
Sure.
Would you mind rephrasing that a little bit for them as well?
Desde luego, me da pena saber que hay posiblemente algunos sacerdotes que quieren desanimar a la gente a recibir la vacuna. En cambio, la iglesia debiera estar buscando formas de dar a la gente más confianza para acercarse a recibir la vacuna. En algunas comunidades se están dando la vacuna en la misma parroquia, una iglesia, para que la gente no tengan miedo de acercarse, porque tal vez van a quedar descubiertos por los oficiales de la inmigración. Hay muchos sitios donde uno puede ir y sin tener que presentar documentos y recibir la vacuna tranquilamente sin arriesgar a ser descubierto si uno está indocumentado. Así, yo quiero animar a toda la gente que vayan a buscar la oportunidad de recibir la vacuna cuanto antes, porque por su propia salud y la salud de todas las personas que les rodean.
Thank you so much, Your Eminence. Let's see, next few questions. What can we do to protect those who truly are unable to receive a vaccine for medical reasons? Maybe Dr. Ryan, you could start us off with that.
If they really can't, so I'll flip it also. We have patients who are on, for whatever reason, because they're immunocompromised, either because of medicines we're giving them for other conditions or because they have lymphoma or leukemia, et cetera. There are some patients who vaccines just don't work in. So that's a group that we really have to be careful with, because those individuals, we're having a real problem trying to protect them. And for those individuals, they should be in close contact with their physicians and their healthcare providers. We may start giving them antibody on a regular basis if we're in the middle of a flare, but the take-home message is I wouldn't worry about at the medical level yet. They should just be as cautious as they can. Individuals around them should be cautious to ring protect them. And so even if I'm vaccinated, if I was dealing with somebody who was severely immunocompromised, I would still wear a mask, because I wouldn't want to take the small chance that I'm asymptomatically still passing it on to them. So those individuals we should be very careful with as taking care of our neighbors as best we can.
And would you say the same, Dr. Ryan, about the variants? Would you continue to wear masks indoors because of these variants coming out if I'm vaccinated?
No, I thought Rochelle Walensky said it well this morning, so at the CDC. So, I mean, I think individual municipalities might come up with their own rules, et cetera, and it's a free country, groups can do what they want to do. But I don't think we have to wear masks indoors if you're vaccinated, et cetera. I would just adhere to the general CDC guidelines. Now, for instance, at Mass General, we wear masks indoors because we deal with so many immunocompromised patients, et cetera. But when I go to the grocery store, et cetera, unless I know I'm traveling with someone who's at risk or something, I don't feel compelled to wear my mask indoor right now.
Great, thank you so much, Dr. Ryan. A frequent objection heard from, as they call themselves, traditional Catholics is don't be afraid of death. Have faith. We should live each day ready to die. Is there a way to counter that within the context of the vaccine? Colleen, do you want to start, or?
Wow, that is a tough one. You know, as we were sitting here and kind of answering some of these questions, the one thing that came to mind also is the rise in mental illness because of isolation, because of this pandemic. So I think we also have another opportunity that the vaccine, the pandemic is terrible, but there are other things that are also adversely affecting our population. For our health system and across the country, we're seeing a rise in mental health cases, and especially those in teenagers and younger adults. And so I think, trying to get past the pandemic and getting people back into the social part of our lives is also an important aspect. As it relates to trying to get traditionalists who would be against or anti-vaxxers, I don't know that I have any more wisdom other than coming at it from the greater perspective of us as a community and what's in the greatest good for all.
Would you have anything to add, Your Eminence?
Yes, I would say that, certainly we're all going to die, but the fifth commandment has a positive obligation to protect our health and not to put ourselves in harm's way unnecessarily. And so I think it's kind of a blasé attitude to say, well, we're all going to die, so it doesn't matter. We can put ourselves at great risk. I don't think that's following the traditional morality of the church. We need to take care of ourselves and to avoid unnecessary risks.
Thank you. Thank you, Cardinal. Mauricio, I wonder if you would be willing to address this. There's a concern here where the common good is being ignored, public debate has been silenced, and the science has been manipulated. I wonder if you wouldn't mind speaking to that, how the science has supposedly been manipulated.
Okay. Again, I don't have any evidence to that effect. Again, the science has been the science behind the development of these vaccines is next to you can say almost miraculous. To be able to develop a vaccine in such a short time, and to be able to deliver that vaccine to so many people around the world is just it's something that has never been done before. This goes beyond anything that the scientific community has ever been able to achieve in the past. So to say that that science or that there has been manipulated or I guess to me that is it's just very difficult even to conceive. And it's really important to really to understand how it's really about the importance of I think goodness in this case is what has played a huge role in the scientific development.
Very good. Thank you, Mauricio. Dr. Ryan, we had someone ask, you had mentioned at one point, one vaccine was causing something in women and another was causing something in men. And there was if you could revisit that.
Sure. So the slight increased risk of lightning strike for clotting is usually seen in women, and it's usually seen with the DNA vaccines.
Okay.
The slight increased risk of about the car accident is usually seen in young men, and that's with the RNA vaccines.
RNA vaccine.
And to go back to what Maurizio said, science is, I agree, science is transparent. I mean, it comes from the word schio, to cut open. We get scissors from that, to cut open, to expose, to know. And scientists rip each other apart all the time. It's in our DNA. I mean, our job is to either confirm or refute. And so science itself is apolitical, but I'll tell you what is political is public health. Public health, by definition, just like Tip O'Neill said that all politics is local, all public health is political, right? Are we going to prevent sexually transmitted diseases? Are we going to try to decrease gun violence, etc.? Once you get into public health, you're into politics, by definition, the polis of our species. And so having said that, don't go into the political arena for public health, go into the one-on-one arena with Miss Walters and her team, because you do the clinician things. When you do clinical things, that's not public health. That's a dyad between two people with what's best for that person, taking everything into account. When we do public health, we have to put on a political hat. It's just the nature of the beast.
Very good. Thank you.
Could I ask just for clarification? I don't know myself. I think the RNA is Moderna. What are the other common names for the DNA and RNA, and ultimately maybe the protein type of vaccines?
Yeah, so the RNA vaccines in the United States go by Pfizer or Pfizer-BioNTech. That's one RNA vaccine. The other one is Moderna. And then the DNA vaccine in the United States is often called the J&J vaccine for Johnson & Johnson, or the Johnson vaccine, or the Janssen vaccine. It's one big company. The DNA vaccine that's being used in COVAX and in Europe is often called the Oxford AstraZeneca vaccine or the AstraZeneca vaccine. The protein vaccine that may or may not get approved in about 3 months has come from a company called Novavax, which is out of Maryland. And the Europeans, GSK and Sanofi, are trying to make a protein vaccine also that may or may not come down the pipe in the next 3 to 6 months. And then most of the world is getting many others. There's the Sputnik vaccine from Russia. There's the Sinopharm vaccine or the Sinovac vaccines in China. There's the Bharat vaccine out of India. There's many vaccines that are out there. That's how we got up to 3 billion people immunized already.
Right. Great. Thank you, Dr. Ryan. And I think you answered this already, but if you could just quickly speak one more time to the length of time that a vaccine provides us protection.
Yeah, so after you get a vaccine, you're probably, I'll give you the simple version, you're probably very well protected for 6 to 12 months, if not longer. Data suggests that you get very nice memory responses in your bone marrow, suggesting that when you do see the virus, whenever that is, that you'll probably rev back up right away. We may want to give you a booster at about the 12-month mark if the planet is still hot. That's the simplest summary.
Very good. Very good. Thank you, Dr. Ryan, again. Cardinal O'Malley, I don't know if you know the answer to this, or maybe Mauricio. The development of each of the 3 current vaccines, this person is writing, currently in use, have been involved in aborted fetal tissue, human embryonic stem cell derivation lines. If you could, if maybe Mauricio, I don't know if you maybe know the answer to this, whether or not there's truth in that, and Cardinal O'Malley, maybe a follow-up with the morality behind it.
Okay, I haven't seen any evidence to that effect. So, so no scientific evidence that that can support that claim.
So if I can add on top of Maurizio, so it's absolutely right that there's no fetal tissues in the vaccines. For full disclosure, the DNA vaccine, as part of its manufacturing process, it grows the DNA in a mortal cell line that was derived from fetal tissue from an abortion, unclear of its provenance, in the early 1970s. It's a standard cell line that many companies use. It wasn't done for this purpose. And it's a standard processing step for one of the components made in the vaccine, but there's no fetal tissue in the vaccine, etc. It's DNA of the virus. The other 2 RNA vaccines don't use anything in their production from fetal tissues, but each of them has a test to make sure that they don't hurt human cells. And those human cell tests are done on fetally derived cells, also that were originally isolated in the early 1970s. Now, recognize that we don't want to inject things or give drugs or anything to humans without testing them a lot. So we test them in animals, and we test them in human cell lines in the test tubes. And only when they look safe do we go on. Now, human cell lines don't like to grow indefinitely in test tubes, so they come in 2 flavors. They're either cell lines from cancer cells, and they don't predict too well what would actually happen in a normal cell because those screw cells are really screwed up.
Right.
Or they're fetally derived cells.
Okay.
And the provenance of these cells is uncertain, but they've been around for over 50 years, and they're used in almost every medications probably that you take. They were tested at some point in these cell lines.
Very good. Thank you, Dr. Ryan, for that clarification. Cardinal, if you could come quickly just with a...
Certainly, the Holy See has said that, of course, we want to encourage pharmaceutical companies to use stem cells rather than the tissues that have come from these abortions. But the connection to the virus is so remote. We're talking about an abortion that was carried on decades ago and that was not performed in order to produce the vaccine. It's very remote, and therefore the Holy See has said that taking the vaccine is an ethical decision. This discussion was raised first of when they had the rubella virus vaccine, which was the same type of thing where somehow there was a connection to these tissues, and once again the Holy See at that point determined that an ethical decision would be to use the vaccine, and the Congregation for the Doctrine of the Faith, as well as the Academy for Life in the Holy See, have repeated that and made it very, very clear. And
Great. Thank you so much, Cardinal. We have actually reached the end of our questions. So with that, I'll turn it over to you, Steve, to introduce our closing prayer.
Thanks, Janine. And I want to thank, honestly, I want to thank everybody. This was an extraordinary discussion, an extraordinary evening. I'm so grateful, Your Eminence, that you were able to come this evening. Maurizio, Ed, Colleen, I cannot remember a panel as interesting or as timely or as critically important as this one, and Franciscan Action Network is just delighted to have been able to have you this evening. I also want to thank our audience this evening for the questions posed, for your attendance, and you know, I hope that you take the answers and you know what you've learned this evening with you into your discussions with your family. I'm certainly going to talk to my sister-in-law, for example, into your discussions with your family and your friends and so forth about this. But thank you all very much. And with that, let me introduce Sister Margaret Mary McGee, Franciscan. Sister Margaret, would you say a closing prayer for us this evening?
Yes, thank you, Stephen, and thank you to all the panelists for such an engaging conversation and lots of good information. So let us pray. Loving, gracious, and good God, you desire our well-being and wholeness. We hold in tenderness and prayer all those who are suffering in our world at this time. We grieve the precious lives lost and the vulnerable lives still threatened with this virus. We ache for the families, neighbors, and all who live in anxiety and fear before an uncertain future. We pray that love, not fear, will go viral to heal our world. Inspire all leaders to discern, to choose wisely, speak and act for the common good of all. Help us to live with compassion and attentiveness and guide us in new and creative ways to be together in spirit and in solidarity. We pray, dear God, that you fill us with deeper trust in your faithful presence and merciful love. You are our God who never abandons us. Amen.
Amen. Thank you, everyone. Bless you all.
Thank you. Thank you, Steve. God bless.
Thank you.
Thank you, Steve. Thank you very much. Thank you to the Franciscan Action Network.